right, so morning, everybody. So we're going to go through another ECG today. And it's a short week. I think we'll only do one session this week because Wednesday is a holiday. Friday, I'm also not around. I'm on leave. I had to take my days before June finishes. So, how was last week, Thursday and Friday? Was it okay? From what I heard, it was actually quite quiet. So it looks like I'm the bad luck charm. When I come, that's when the patients come. All right. But anyway, let's get back to our ECG for today. All right. So our first slide. As always, we analyze axis, analyze rhythm, which we're going to do, analyze rate, analyze each zone. This is just a reminder for each of us. All right. So we're going to look at the ECG on the next slide. All right. But as always, we start with the history and we start working on differentials, and then we match our ECG to our differentials. All right. So 53-year-old man with left arm squeezing sensation and nausea for 8 hours. Now pretend you haven't even seen this, all right? You're walking from your car, you're coming in, or as soon as you get the handover, nobody's touched this patient. They just tell you, 53-year-old man with the left arm squeezing sensation and nausea for 8 hours. What are your differentials from there? There should be one right at the top of the list, which is ischemia. Okay, there should definitely be ischemia at the top, all right? So, that's why you'd run for your ECG, because, we all know left arm pain, left jaw pain, squeezing, pressure, any of those types of descriptions, I feel like I can't breathe, like somebody turned something off, do you guys know Richard Pryor? He's an old comedian. If you ever get a chance, his videos are on YouTube, and you must hear him describe his first heart attack. It's like he was walking, and suddenly his body just said, no. and he just stopped, and he fell to the ground. But you must hear his description, and how it's. But that's the type of histories that we get, right? Now, what could be the other differentials? You've got left arm squeezing, so there's neuro as well, right? So any sort of neurological deficit. So in other words, could it be a C-spine issue that's causing compression? Because we know it's not trauma. I mean, we already know it's not trauma. So could there be something like that? Nausea as well. Could it be central nervous system? Because that can also cause, if there's a problem in the motor homunculus or in the sensory homunculus along with nausea. So in other words, intracranial can't be excluded, all right? Anything else that you could think of that could possibly lead to it? There are some more, let's say, less common causes, all right? So for example, what about an embolus? We always think of pulmonary emboli and DVTs and things like that, but you get upper arm emboli as well, So what about an upper arm embolus? It could happen, it's possible, Would it lead to nausea? Not necessarily, but I'm just giving you an idea of how you have to think about it, all right? But I think even if you don't know ECGs very well, even looking at this, you'd already be scared of the heart, all right? So let's say we did get this patient comes in, we then put on the ECG, all right? And then this is what we see, all right? So immediately, even before you analyze it, just eyeballing it, you can really see, no, something's wrong here. Now your question is, okay, I've got to really look at it and see what's wrong. Okay, so we start with the basics, all right? So we look at our axis first, okay? So let's draw our axis out, and then we'll take it from there, okay? So let's put that. Sorry. Okay, so let's just draw our axis first. All right, so we remember our 4 quadrants: normal axis, left, extreme right, and right, okay? Then we've got lead 1 here, and we've got lead AVF at the bottom. All right, so let's start with lead 1. All right, so which way is lead 1 pointing? Downwards, all right? So if lead 1 is here, that means it's seeing electricity moving away, all right? So that's why it's seeing a negative. So that means we've either got an extreme right or a right axis, all right? So we know for sure we don't have a left axis. We know for sure we don't have a normal axis, right? Let me just look right. Okay, and let's look at AVF, all right? So which way is AVF pointing? Difficult, it's biphasic, huh? It's biphasic. So what that means, let me just put this on the video, all right? For those who are going to be watching later, right? Just put it. Have you tested for COVID? I'm just hearing the cough and I'm wondering, all right? So we've got AVF that's biphasic, all right? So what that's basically telling us, imagine I'm AVF, right? So I'm looking at things from this point of view. So what I'm seeing first is I'm seeing a positive, then a negative. So you've got to imagine the lead also has sort of vision, it's looking like in that direction. So what it's seeing is it's seeing electricity coming towards it, and then it's seeing electricity moving away from it. So when you see a biphasic, like what we see here, essentially what it means is that the lead is 90 degrees to the electricity, if you get what I mean, all right? So let me just collapse this a little bit, all right? So in other words, here's lead AVF, all right? So it's seeing electricity moving towards it and then moving away from it, all right? So there's two possibilities. Either electricity is coming from this side to this side, okay, which means that our axis would be here, and we know that it's not there. Or the other possibility is that it's saying moving from this side and then moving to that side. So more likely, your electricity is somewhere in this direction, right? Do you get what I mean, all right? Because if it was moving in that direction, it means it would be somewhere here, and lead one would be seeing it as positive. So instead, what's happening is lead AVF is watching electricity come towards it from that side and then disappear on that side. So it's seeing it come towards it and then go away. I think you need to do your COVID test now. Huh? I'm joking. All right. So in other words, what we, in this case, we have an axis that's exactly here. But for interest sake, we'll just say it's a right-sided axis, okay? Because the axis is not the major thing. However, if we have a right-sided axis like we do in this case, it tells us one of two things, remember. Either the right side has become very large, so it's taking a lot of electricity, or the left side is so damaged that everything's being shunted to the right-hand side, which in this case, just looking at this, we would suspect is more the case, all right? Okay, let's look at the rhythm. So we don't have a rhythm strip, but even if we start looking, let's say at lead 2, for example, which would be our rhythm strip, what do you notice over there? Does that P wave look normal? Not really, isn't it? It kind of goes there and then it has like this little step and things like that. Even if we look at it here in AVF, it kind of has this little step. Here we see it in V1. So there's something going on with that, right? Now, even though it's not of great importance, I'll just go through it. So basically what we're seeing is the first part of your P wave is your right atrium, all right? And the second part of your P wave is your left atrium, okay? So what we're actually seeing in this case, one is that we're actually seeing a right atrium that's kind of functioning okay, and then a left atrium that's taken some strain, okay? In other words, it's not at its normal functioning level. The amount of electricity that it's producing is less, and it's taking longer to actually produce that electricity. That's why it's drawn out. So given the overall picture that we're seeing, we can assume that this ischemia kind of passes to the left atrium as well, okay? All right, that's very good. But then if we look at the rest of it, our PR interval, we're looking at 1, 2, 3, 4, 5. So it's a bit exaggerated, but not tremendously, okay? Our QRS complexes, are they narrow or wide? They narrow, okay. Does the QRS follow every P? Yes, it does, all right, it does. And are they regular? Yeah, they're relatively regular, all right? So except for the form of the P wave, everything else is, or a slight lengthening, but otherwise there's not much, all right? And then our rate that we're looking at, let's just look at 1, 2, 2.5. So we're looking at about over 100. So we've got a tachycardia, all right? So the way that you work it out is you take the distance between the blocks, and so this is like 2.5, right? And you take 300 divided by 2.5. Right? So it's about 115 in this case, somewhere around there, okay? But in any case, it is a sinus tachycardia because everything is sort of falling okay, maybe with a bit of a first-degree heart block, okay? All right, now we've gotten that out of the way. Now we're coming to the most important things, all right? So let's start with where we can see the problem, all right? Then we'll come back to everything else because otherwise it gets a bit boring. So let's look at lead V1 and V2, okay? So what's the first thing that we notice here? What do we call these waves? Q waves, very good, eh? Q waves, all right. So what do Q waves tell us? That there is ischemia. It just doesn't tell us when. And how long is our patient sick for? 8 hours, eh? So that means the ischemia has been carrying on. It may be old, but it may also have developed over the last few hours, all right? You can cough, it's okay, don't worry. Yeah, I'm just checking. But what it means is that if you have these, all right, so remember Q waves tells you that the whole wall is now involved, right? So the entire thickness of that myocardium is 1, all right? All right, what else do we notice in V1, more specifically in V2? Very good, so these massive ST elevations, eh? All right? And our patient is 53, so any patient more than 45 should only have 2 blocks. And this is already going to about 3, 3.5. But even then too, you can see this is quite typical of an ST elevation. Okay, so that's the septum. So we know it's involving the septum. Then we come to the anterior, V3 and V4. What do we see? Very good. Big ones, small ones? Big ones, eh? And what else do we notice? Again, sorry, Q waves, Q waves. Eh? All right, so it's telling us this ischemia is quite widespread. Eh? All right, and then what do we see in V5 and V6? Again, ST elevations and Q waves. Eh? So that means how much of the left ventricle is involved? I mean, we've got the septum, we've got the anterior, we've got the lateral border. How much of the left ventricle is involved? Practically all of it. Eh? There's not much that's left. Okay, everything's kind of. Then we go to our last bit of the lateral side, which is lead 1 and lead AVL. And what do we see again? Very good. There is an ST elevation, and Q waves. Very good. Eh? So our patient has a massive infarct. Eh? Essentially, all of that left ventricle is dying. So are you going to go for tea? Going to have a smoke? No. Great. You barely even breathe. And make sure that you're with this guy. Eh? All right. But even though we have so many ST elevations, we still need to look for reciprocal changes. In other words, there must be some ST depression somewhere. Great. So let's have a look. What do we see in lead 2, 3, and AVF, the inferior leads? What do we see? More specifically in lead 3, you can see a little ST depression. Eh? So even though it's not pronounced, and it's more in lead 3, but it is there, right? It is there. So some of the reasons for that, it could be lead placement, right? Leads may have been placed incorrectly. That may be why we're not seeing a proper ST depression. But the fact that we can see one, and specifically here in AVR, that's where you can actually see your ST depressions quite a bit, all right? So there's no way we look at the other differentials. This is a myocardial infarction, all right? So you've got to now phone Dr. Dlamini, in our case, at 2 in the morning. So what are you going to tell her? Are you going to wait for enzymes? No, you're not waiting for enzymes, isn't it? Why are you not waiting for enzymes? Because you're telling her your patient has a septal involvement, anterior segment involvement, lateral wall involvement, and your patient has ST depressions. You have massive ST elevations with Q waves, and your patient's been sick for 8 hours. So what you're going to tell Dr. Dlamini, not that Dr. Dlamini won't understand, I'm not picking on Dr. Dlamini, I'm just giving an example of a physician. But what you're telling your physician, and if your physician is just woken up, so it's 2 in the morning, she was asleep, you're going to tell her this patient has been sick for the last 8 hours. We've got evidence of full myocardial ischemia with the Q waves. We've got ongoing ischemia because of the persistence of the ST elevations. So this patient needs reperfusion. Agreed? This patient needs to be reperfused now. Okay, all right. So in other words, Dr. Dlamini also shouldn't dress and put makeup. No, Dr. Dlamini needs to jump in the car and come here now. All right, this needs to be sorted out now. Okay, all right. So let's have a look and see. So we've got, as we said, a sinus tachycardia, rate of 110. All right, so more or less correct. LAE stands for left atrial enlargement, which is something that we saw. Okay, sort of. All right, we didn't know exactly what it was, but we knew that the left atrium is not okay. And an acute anterolateral MI. So they call it anterolateral because V2 is sometimes regarded as an anterior lead, depending on how it's placed. But we know that it's quite extensive. Right? So the rightward axis in this case is caused by a lateral MI. So the lateral side or the left side of the heart is badly damaged. So that electricity has nowhere to go. So the electricity gets shunted back to the right-hand side. Okay. So other causes, LPFB, RVH, acute embolism, emphysema, lung disease, ventricular activity, blah, 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 blah. Okay. All very good if you can remember it. If you can't remember it, just Google it. Comes up as a little list. All right. Don't worry. So normal young or slender adults may have a horizontally positioned heart, can also demonstrate a right ECG axis on ECG, something nice to know. All right. The patient demonstrates evidence of a large transmural MI, Q waves, with ongoing ischemia. All right. So in other words, our patient has had damage to the entire myocardium and is still having ischemia that's ongoing. So what are you going to do? Even before you phone Dr. Dlamini, what should you have done for this patient? Are you giving them aspirin? Yes. Are you giving them morphine? Yes. How much of morphine are you going to give the patient? 5 milligrams, and increase up to 10 in a stepwise fashion. So why are you giving morphine? 2 reasons. Number one, pain. All right. It does have a bit of a vasodilatory effect, but not too much. But more importantly is that it has an effect on adrenaline. Right? You're making a patient high. Okay. The reason for that is you want to decrease anxiety. No matter who you are, even if you've never been to school, you don't even know 1 + 1, but you know what a heart attack is. Agreed. And you can see doctors are rushing around and looking worried. And somebody will say, ischemia, heart attack, something. So what's happening to your heart? So what does your heart need to be able to pump faster? It needs blood, it needs oxygen. What are the 2 things it's not getting? Blood and oxygen. So by your patient increasing the anxiety levels, their cortisol and adrenaline levels, they're actually increasing the ischemia. So your morphine helps in that regard. It calms them down. Your patient is literally goofed out of their mind. All right. Morphine's a lovely thing. If ever you're having a bad day at work, just steal some. Makes the day go much faster. Okay. But what I'm saying is it calms that down. All right. Okay. What else are you giving this patient? We said they need oxygen. All right. So what's our normal saturation on room? 94%. Agreed. Is there any way you can improve that? Yes, you can give them oxygen via face mask. Agreed. Have you taken cardiac enzymes, blood gas? You've done all of that as well. Agreed. Anything else you can do? Even in our setting, whether you're at a district, regional hospital, clopidogrel, or any other sort of platelet inhibitor, if I can put it that way, right? Aggregation inhibitor. So these are all things that you can do already. Okay, now, Dr. Dlamini is not picking up a phone. Fast asleep. Okay, just doesn't want to get up. There's not much that you can do. Agreed. You can't, you don't know where she stays. You don't have an alternate number. No other physicians are picking up. You try to phone Dr. Faz Mohammed. Dr. Faz Mohammed is on leave. Dr. Tembela just shouts at you and puts the phone down. Right? So what are you going to do? You can't say, hey, I don't normally do these things, so the patient just has to die. Agreed. Or you're working in Dundee Hospital, which you guys have already done. Right? Dundee's got load shedding. The person at the switchboard fell asleep. What are you going to do? Do you have options? Yes. How are you going to reperfuse this heart? Are you going to thrombolize this patient? Yes, you are going to thrombolize this patient. So we're going to get into that now, right? What does it mean to thrombolize? Because some of you may be stuck in that situation, right? Now, what we're going to do as well, we're just going to have a look at a little video that talks about infarcts, all right? What is a heart attack, right? And how would you explain it to your patient? Okay.
What is coronary heart disease? Coronary heart disease, or CHD, refers to a narrowing of the coronary arteries, the blood vessels that supply oxygen and blood to the heart. It is also known as coronary artery disease. It is the utmost cause of major illnesses and deaths worldwide. Coronary heart disease normally happens when fatty deposits called cholesterol accumulates on the artery walls, creating plaques. The arteries are being tightened and makes it difficult for blood to flow to the heart. CHD may also be caused by blood clots or thrombus that totally occludes the blood flow. When these blockages occur, it is called coronary occlusion. Most of the blocks in the artery are caused by a combination of atheroma in atherosclerosis and thrombus in thrombosis. Atherosclerosis and arteriosclerosis is the narrowing and hardening of arteries by atheroma or cholesterol deposition, so they could not dilate. The blockages or occlusion then causes myocardial infarction or heart attack, which is the sudden slowing or stopping of contractions of the heart muscles. CHD commonly induces angina pectoris or chest pain and shortness of breath. This could be due to the malfunction of the cardiac muscles. Its parts could die owing to the lack of oxygen, supposedly delivered by the clotted blood. CHD can also be caused by hypertension. It happens when blood flows through the blood vessels in a consistent high pressure. Causes of coronary heart disease. CHD can be caused even by genetics. Certain mutations in the genes are linked to it, but mostly this disease is due to unhealthy lifestyle habits. A study published by PLOS in 2017 even linked CHD to the use of high heat in food preparation. An unhealthy diet rich in cholesterol and saturated fats leads to high blood cholesterol levels, worsening the situation. Smoking is one of the most damaging lifestyles to your heart function. Toxic contents in tobacco limit the blood's ability to carry oxygen. The carbon monoxide in cigarette smoke relocates some of the oxygen supposedly in the blood. This condition forces the heart to work harder to supply enough oxygen, then results in increasing heart rate and blood pressure. Women who smoke or inhaled second-hand smoke and take birth control pills are at greater risk of having a heart attack or stroke than those who do not. Both the smoke and pills carry increased risk of blood clot. On top of all, being stressed lets out adrenaline hormone and raises the heart rate and blood pressure. Prevention. Make plans to stop smoking and do not start one. Avoid all forms of tobacco use, as all are equally harmful. Set out a diet enriched by fruits, vegetables, and whole grains. It helps to protect our hearts. Prefer beans, low or free fat dairy products, lean meats and fishes for healthier diet, and eat less sugar and salt. Limiting certain fats you eat is also important. Start to exercise regularly and maintain weight. Finally,
So what I love about that video is the fact that they just showed her the good food and she felt better, which if only it really worked like that. Eh? But listen, I know it's a bit of a simplistic explanation, but just something so people will understand. So you need to now thrombolize this patient. Even before you start thrombolizing the patient. Now, streptokinase is the most commonly available one. You'll even find it at district level hospitals, some of the bigger CHCs and things like that. There's something that we call a thrombolytic checklist. All right. Now, the thrombolytic checklist in itself is quite a long thing. It covers about, I'd say there's about 7, absolute contraindications, and there's about 12 relative contraindications to thrombolysis. All right. Now, in our case, it lies here on the side of our emergency cupboard. All right. We've got the checklist over there. So there's certain things. For example, your patient has a bleeding disorder, or your patient has really recently had like a hemorrhagic CVA, has had recent facial trauma. You know, there's a whole lot of things you have to go through. And in those cases, you cannot thrombolize the patient, right? Artificial heart valve, there's a whole lot of things, right? And then there's relative contraindications. For example, you've put a subclavian CVP. Your patients had to undergo long-term CPR. There's a few things that are relative contraindications. So what a relative contraindication means, you have to weigh the pros versus the cons, all right? And then you go from there, okay? So streptokinase is the one that's most commonly available. So what does streptokinase do? Streptokinase goes into the body. It finds every bit of fibrin, every bit of clot, and it says, right, you're free, and they all just run away. Okay, so those atheromas, arteriomas, everything, basically what happens is it breaks them down completely. So it allows blood to flow through that vessel. Okay, it doesn't dilate the vessel. It doesn't remove the the lipid deposits. It just removes the clot that's surrounding those lipid deposits, so that you are going to get some flow that's through there. Okay, so how do you give it? All right. How much is that? 1.5 million is what it should say. I don't know why it's put like that. Sorry. Streptokinase, 50 mils of saline or dextrose 5%. All right. It's administered as an IV infusion at a constant rate over 30 to 60 minutes. All right. Now, there's a specific way that you put it together. Okay. And that is that it must basically you must use all the powders so that you get a proper amount and things like that. Do you give it via CVP? No, it's given via peripheral line, right? Because as soon as you get into any of your big vessels, I'm just saying this because I've seen people, when we said we're going to thrombolize, suddenly bring out a CVP pen. Like, why? It's like, but it's a big medication. No. Doesn't mean big medications need CVPs. You're actually causing your patient more harm, because as soon as you remove that CVP, the patient's just going to bleed, okay? Now, do you need to know how to use streptokinase all the time? No, I'm just showing it to you just so that you're aware of what it is, okay? Generally, somebody should be advising you, somebody should be taking you through the process. But like I say, if you're stuck in a situation where you don't know, even if you forget the dosage, at least you know it exists. At least you can get a bit of signal on Cell C or Telcom even, and just check up the dosage, check how to do it. But remember that name, streptokinase. Right? Are there alternatives? Yes, alteplase, there's so many others, but we don't necessarily have access to them. Streptokinase is the most commonly used one and the most widely available. Okay. If you have an ICU in your hospital, definitely it should be there. If you have a theater complex in your hospital, it should be there. There should be something. Okay. And if worse comes to worse, heparin. All right. Heparin. Okay. But I wouldn't advise it for an MI, but if worse comes to worse. Okay. So what is our other option? PCI. Percutaneous coronary insufflation, right? Angioplasty. You guys know how it's done? No, let's have some fun. Let's watch it. All right.
Coronary angioplasty, also called percutaneous transluminal coronary angioplasty or balloon angioplasty, is designed to restore the flow of blood through coronary arteries narrowed or clogged by atherosclerotic plaques or blood clots. When you arrive at the hospital, an intravenous line will be started. You will be placed on a heart monitor, and you will be given an oral or intravenous sedative to help you relax. Most coronary angioplasty procedures last between 30 minutes and 3 hours. The doctor numbs the skin in your groin area and inserts a needle into your femoral artery. Once the needle is placed, a guide wire is passed through the needle and gently guided through the arterial system to the heart. The needle will be withdrawn and exchanged for a small flexible tube called a sheath, permitting access to your femoral artery. At this point, you will be given a blood thinner to reduce the risk of blood clots. Next, a soft, flexible catheter is slipped over the wire and threaded up to the heart. The procedure is monitored using a continuous X-ray imaging device called a fluoroscope. You may feel pressure as the wire and sheath are inserted through the groin and pushed through the artery, but you will not feel their movement inside your arteries. At this point, your doctor will remove the guide wire, position the tip of the catheter just inside the coronary artery to be treated, and inject a special dye. The dye allows the fluoroscope to take X-ray images, called angiograms, of the artery's interior. Any blockages will be clearly identified as the arteries fill with the dye. You may feel flushed or slightly nauseated when the dye is injected. Once the blockage is identified, your doctor will insert a flexible guide wire into the artery and advance a balloon-tipped catheter over this wire and into position at the site of the blockage. Rapid inflation and deflation of the small balloon pushes the vessel wall out, reestablishing blood flow through the artery. You may feel some chest pain while this is happening. The same procedure is repeated for each blockage being treated. Afterwards, your doctor will withdraw the deflated balloon and catheter from your arteries. Some patients will receive a coronary stent, which is a small tube made of wire mesh designed to prop open the artery once it has been treated. A collapsed stent is placed over the deflated balloon as it's moved into position. When the balloon is inflated, the stent expands and locks into place. After the balloon and catheter are withdrawn, the stent remains behind to hold the artery open permanently.
I love how they say permanently. If only it was like that. Yeah. Now the thing is, I found some videos that were more medical, but it was just videos of guys doing the actual procedure. So the video is just behind the dude's head, and you're just watching him doing stuff. He's not even talking and things like that. There were quite a few like that, right? But just so if you've never understood what PCI is, that's what PCI is. Okay. All right. I think that's the end of it. Yeah, didn't have anything else. So just for you guys to have an idea of what it is and what we do. But like I say, most of the time we would end up doing thrombolysis. Okay, if worse came to worse, we don't have a catheter lab here. So the closest one is Gray's Hospital, all right, to us. And that's where we send patients with persistent ischemia. Okay. Any questions? Anything I'd like to know? Today wasn't a heavy one. It was just to see some interesting stuff besides what we normally look at. So I hope it was okay. Hope you guys enjoyed it. All right, just to learn something new. And yeah. Okay, I'm just going to repeat the question for those on Zoom. So can we thrombolize in casualty? Yes, we can. We have done it before. In our case, though, because ICU is so close, we normally transfer the patient there. The reason being it's easier for the physicians to actually monitor the patient in ICU. However, we've had cases where our patient, there were no ICU beds, the monitors were not working, whatever it may be. and we just reperfuse them here. Now, I didn't get into reperfusion very heavily, but there's a few things that you watch out for after reperfusion. But it's not something nice to do, if I can put it that way, for the simple reason that the amount of monitoring that the patient needs is not something we can really do. So the patient, for example, needs to be on a 12-lead ECG at all times. You need to have, how do I explain? Relatively constant visual of what's going on in that heart to see that your thrombolysis is working. There's specific rhythms we're looking for, there's specific things that indicators in terms of the vitals and things like that. And in a busy emergency department, it's not the best thing because you need to have full attention on that patient. If an MVA comes in all of a sudden or a little kid crashes, you're not going to move away from your MI patient. So we have had to do it, but I don't like to do it. If you get what I mean, it's like doing an emergency Caesar. We have to do it, we'll do it, but we don't like to do it. You know, if there's a better place to do it, we'll do it. Okay, all right. So later on in this year, I want to discuss reperfusion rhythms with you guys, but it's not now. We haven't reached that stage yet. Okay, all right. Any other questions? Anything anybody would like to know? Shall we conclude for today?
Can I do your question, Doctor?
All right. So thanks, everybody. If there are questions, you're welcome to ask me later as well. And yeah, we'll just stop it then. Thanks. Bye.